The next oration is WCCPCI 2012 Dr. W. Selvamurthy oration. This year this oration is being conferred on Professor Amal Kumar Banerjee from Kolkata, and he would be speaking on heart failure management strategies for 2012. May I invite the following dignitaries to please chair the proceedings: Colonel S.K. Parashar, Dr. H.K. Chopra, Professor Harshvardhan, Dr. Shikha Sharma, and Dr. Ajay Sinha. May I request Dr. H.K. Chopra to kindly introduce Dr. Selvamurthy and Professor Banerjee. I would once again like to invite Colonel S.K. Parashar, Dr. H.K. Chopra, Professor Harshvardhan, Dr. Shikha Sharma, and Dr. Ajay Sinha. Professor Banerjee will have 15 minutes, followed by 3 minutes for the oration protocols. Thank you very much.
Ladies and gentlemen, it's really a great pleasure and honor indeed for me to have this prestigious oration of W. Selvamurthy bestowed upon none other than the President of SAARC Cardiac Society, Dr. Amal Banerjee. Amal Banerjee is the past President of National CSI and also the past President of API. I just want to say a few words about Selvamurthy. He is a very renowned scientist of India, distinguished drug controller, chief controller of India, DRDO. We are very privileged. He is the first man who did a lot of work at the Mount Abu trial from India. The whole study was supported by DRDO. We are highly honored that this oration is given to none other than Dr. Amal Banerjee. I request Dr. S.K. Parashar to please come on the dais here, and Dr. Haryawala, please come on the dais. Mukesh.
Respected chairpersons and my friends, I will discuss a brief overview to an updated approach to the management of heart failure based on the latest European Society of Cardiology Guidelines 2012. What is new? I would rather say what is the highlight of 2011 regarding the management of heart failure. An expansion of the indication for mineralocorticoids, that is the aldosterone receptor antagonists, a new indication for the sinus node inhibitor ivabradine, an expanded indication for cardiac resynchronization therapy, new information of the role of coronary revascularization in heart failure, recognition of the growing use of ventricular assist devices, and emergence of transcatheter valve interventions. All of you know the clinical situations leading to heart failure, ischemic heart disease and myocardial infarction, particularly in our country, valvular heart disease, chronic hypertension, non-ischemic heart disease like idiopathic dilated cardiomyopathy, metabolic causes including inflammatory and infiltrative diseases. Now to diagnose, basically heart failure is a clinical diagnosis. To diagnose heart failure with reduced ejection fraction, we require 3 criteria: symptoms and signs of heart failure, and documented by echocardiography, reduced ejection fraction. To diagnose heart failure with preserved ejection fraction requires 4 conditions. Signs and symptoms of heart failure: normal or mildly reduced left ventricular ejection fraction, but LV should not be dilated. And fourth one is the relevant structural heart disease, LV hypertrophy or left atrial enlargement, which has got paramount importance, particularly diagnosis in the and prognosis of the heart failure patient with preserved LV function and diastolic dysfunction or so-called diastolic heart failure. All of you know signs and symptoms of heart failure are not so specific, but you have to diagnose on clinical grounds. Typical symptoms include breathlessness, orthopnea, PND, and all you know, ankle swelling, nocturnal cough. Less typical, the nocturnal cough, wheezing, weight gain, all these things. Regarding the signs, more specific, elevated JVP, hepatojugular reflux, third heart sound, and the symptoms, signs of the LV enlargement, that is outward and lower displacement of cardiac apex. Less specific, peripheral edema, reduced air entry, tachycardia, irregular pulse, tachypnea, hepatomegaly, all these things. Now to investigate, the most important is transthoracic echocardiography is recommended to evaluate cardiac structure and function, including diastolic function, and to measure left ventricular ejection fraction to make the diagnosis of heart failure, assist in planning, monitoring of treatment, and to obtain prognostic information. ECG to determine heart to rhythm rate, rhythm, QRS morphology, QRS duration, and detect other relevant abnormalities. We should remember a person with suspected diagnosis of heart failure with complete normal ECG, probably the patient is not having any heart failure. Measurement of blood chemistry to evaluate patient suitability for direct renin, angiotensin, aldosterone antagonist and anticoagulation therapy. Detect reversible or treatable causes of heart failure like thyroid dysfunction and hypocalcemia, and obtain prognostic information. A complete blood count is required because all of you know that anemia has got tremendous impact on the management of heart failure. Heart failure itself causes anemia. On the reverse way, heart failure, anemia aggravates heart failure. So anemia should be properly detected and treated. Measurement of BNP and NT-proBNP and MR-proBNP. One thing I should say, assessment of these biomarkers are more important in non-acute cases. Whether we should go for the assessment with echocardiography, I will discuss this thing later on. To exclude alternative causes of dyspnea, if the level is below the exclusion cut point, heart failure is unlikely. Obtain prognostic information. A chest radiograph should be considered to detect or exclude certain types of lung disease or cancer. It may also identify pulmonary congestion, edema, and is more useful in patients with suspected heart failure in acute setting. CMR is a very important investigation where echocardiography is non-contributory or incomplete, particularly in some cases of infiltrative and inflammatory disease of heart. Coronary angiography is recommended in patients with angina pectoris who needs revascularization. Myocardial perfusion or ischemia imaging like PET, SPECT, all this scanning are required to detect viable myocardium. unless we can detect variable myocardium in heart failure, revascularization is not indicated. Left and right heart catheterization is recommended in patients being evaluated for heart transplantation or mechanical circulatory support to evaluate right or left heart function and pulmonary arterial pressure. Exercise testing is considered, particularly all you know, be it the ETT or the 6 minutes walk test, to detect reversible myocardial ischemia as a part of evaluation for patients or heart transplant and mechanical circulatory support, to aid in the prescription of exercise training to obtain prognostic information. Now here is an algorithm for suspected heart failure, acute onset. Blue line for the echocardiography based, red line for the ECG and biomarker based. Echocardiography is the best thing. If the BNP and NT-proBNP is ECG is normal and NT-proBNP is less than 300 picogram per milliliter and BNP less than 100, heart failure unlikely. ECGs are normal, NT-proBNP less than 300 picogram per milliliter and BNP more than 100, then patient should be advised echocardiography to confirm the patient is having the reduced heart failure. In non-acute setting, you can go for the biomarker assays. Here cutoff limit is a bit different. When ECGs are normal, NT-proBNP is more than 125 or BNP more than 35 and ECG is normal, NT-proBNP less than 125 and BNP less than 35, no heart failure. But they will also undergo, you can reduce the cost of echocardiography by evaluating particularly those patients you are evaluating in the OPD basis or non-acute patients whom you will advise the echocardiography. That can be based. This is not mandatory, but you can assess in this way. Now, here is a algorithm for the management, the latest management protocol of heart failure. Diuretics to relieve signs and symptoms of congestion, add AC inhibitor. AC inhibitor. If it is patient cannot tolerate, go for ARB. Add beta blockers. If the patient's signs and symptoms controlled, continue for the therapy. If not, add mineralocorticoid receptor antagonist. Still the patient's signs symptoms not controlled, ejection fraction is less than 35% and patient's heart rate is more than 70, you add ivabradine. But if the patient's heart rate is not more than 70, then you can have straight go for the CRT. Now, what is the indication for the CRT? Patient is still NIHA class 2 to 4, LV ejection fraction less than 35%, QRS duration more than 120 milliseconds, then you can go for the CRT-PEEP, CRT pacemaker or CRT-D. But if the QRS duration is not more than 120 milliseconds, now the recommendation is you can straight go for the ICT. But the still patient is symptomatic, then you can consider digoxin or hydralazine or ISDN. But if still the patient not symptoms controlled, you can consider for VAD or the transplant therapy. Regarding the pharmacologic therapy, AC, all of you know, AC inhibitor when the ejection fraction is the 40%, AC inhibitor, beta blockers and MRA. There should be all are 1A indications for the management of heart failure. And MRA is recommended for all patients with persisting symptoms when patient is class 2 to 4 and ejection fraction is less than 50% despite treatment with an AC inhibitor or ARB beta blockers. Then patient of less certain benefits. I have told what are the indications of the ARB. When the patient cannot tolerate ACI or patient cannot tolerate mineralocorticoid receptor antagonists, then you can consider in symptomatic patients ejection fraction less than 35%, then you can consider ARB. Ivabradine I have suggested. Digoxin is considered to reduce when the patient still symptomatic with these 3 standard regimen, still symptomatic, and digoxin is suggested to reduce the hospitalization. I also discussed the hydralazine and ISDN. N3-PRUFA is got some role to reduce the 2B indications for reduction of the sudden cardiac death. Now ICD. For the secondary prevention, and ICD is recommended in a patient with a ventricular arrhythmias causing hemodynamic instability who is expected to survive for more than a year. For primary prevention, an ICD is recommended in a patient with symptomatic heart failure, NIHA class 2 to 3, and ejection fraction less than 35% despite more than 3 months of optimal medical therapy, who is expected to survive more than a year. Ischemic etiology, more than 40 days post-infarction. Non-ischemic etiology, you know, though the indication is class 1A, the evidence level is B. CRT in heart failure in class 3 and ambulatory class 4. LBV QRS morphology, CRT-P or D in sinus rhythm with QRS duration more than 120 milliseconds, and LBV QRS morphology and ejection fraction less than 35%. Non-LBV pattern, CRT-P or CRT-D should be considered patient sinus rhythm with a QRS duration more than 150 milliseconds and ejection fraction less than 35%. CRT in class 2 heart failure, recommended if patient is sinus rhythm when the QRS duration is more than 130 milliseconds and ejection fraction is less than 35%. In non-LBV QRS morphology, it is indicated when the duration is more than 150 milliseconds, QRS duration, and ejection fraction is less than 30%. Now regarding a brief again the algorithm for the acute pulmonary edema or congestion, intravenous bolus of loop diuretic. If there is a hypoxemia, oxygen therapy should be considered. Severe anxiety or distress, IV opiate should be considered. Then the patient should be systolic blood pressure. Next steps depend on the patient's systolic blood pressure. If the systolic blood pressure is less than 85 millimeter of mercury, add non-vasodilating inotrope. If the systolic blood pressure is between 85 to 110, no additional therapy is needed until the patient is stabilized. If the systolic blood pressure is more than 110, consider vasodilator therapy, particularly NTG. Then, if there is adequate treatment, continue the response, continue the treatment which you are doing. No, re-evaluate the patient's clinical status. HBP less than 85, stop vasodilator. Stop beta blocker if hypoperfused. Consider non-vasodilating inotrope or vasopressor. Consider right heart catheterization. Consider mechanical circulatory support. If the oxygen saturation is less than 90%, oxygen, consider the non-invasive ventilation, consider endotracheal tube and invasive ventilation. Urine output less than 20 milliliter per hour, bladder catheterization to confirm, increase dose of diuretic or use combination of diuretics, consider low dose dopamine, consider right heart catheterization, also ultrafiltration. Heart failure patients, they are very prone to develop atrial fibrillation with heart failure with reduced ejection fraction to control ventricular rate. Beta blocker, no. add digoxin. Ventricular rate not controlled, substitute amiodarone for digoxin. Ventricular rate still not controlled, seek specialist advice per the EP specialist. Heart failure patients with preserved ejection fraction, beta blocker or rate limiting calcium channel blocker. Ventricular rate not controlled, add digoxin, still not controlled, substitute beta blocker for digoxin, still not controlled, same issue. We have to consult EP specialist for consideration of the sinus node ablation or any other therapy. Revascularization in heart failure. After the publication of the STREET trial, revascularization option is the patient with angina and the viable myocardium with left main disease, the patients who undergo CABG. Excuse me. I have only 2 slides. ठीक है, चलो, let me do it. 17 स्लाइड कर दो, और ठीक है, छोड़ा, हम ठीक कर देंगे. ओके. Alternate to CABGs, PCI may be considered as an alternative to CABG in above categories of CABG and PCI are not recommended in patients without angina and without viable myocardium. Now the ventricular assist device, patients more than 2 months of severe symptoms despite optimal medical and device therapy and more than one of the following: LV ejection fraction less than 25% and measured peak VO2 less than 12 ml per kg per minute, more than 3 heart failure hospitalization in previous 12 months without an obvious precipitating cause, dependence on IV inotropic therapy, progressive end organ dysfunction, worsening of renal and or hepatic function due to reduced perfusion and not to inadequate ventricular filling pressure, deteriorating right heart function. Thank you, my friends, for patient hearing.
Thank you, Dr. Banerjee, for such an excellent oration and appraising of all the new developments that are taking place in the field of heart failure. Since this is an oration, generally the questions are not allowed in the oration. So thank you once again. Let's give a big hand of applause to Dr. Banerjee.
Ladies and gentlemen, that brings us to the first leg of the academic deliberations to a close. Thank you very much, gentlemen, for being part of the proceedings, and to Dr. Sharma as well. We would now like to hand over the proceedings for the next 90 minutes to Dr. Avdesh Sharma, and that will be for the inaugural ceremony. It's a protocol inaugural ceremony. The chief guest is His Excellency Padma Shri Dr. D.Y. Patil, Governor of Tripura. May I request Dr. Avdesh Sharma to please take over the proceedings. Dr. Sharma, please. Thank you.